Good morning, everyone. Can you hear me? I hope so.
Yes, we can hear you.
Yeah.
Okay, great. So in these 8 minutes, my goal is to describe what is lymphangiography and how we perform lymphangiography, and to show a few examples of some lymphatic interventions in the thorax. I'm not going to go to other body parts. So you've seen dye injected into the gastrointestinal system and dye injected into the venous system. When we inject it into the veins, we call it venography. When we inject it into the arteries, we call it arteriography. And when we inject it into the lymphatic system, we call it lymphangiography. And lymphangiography was first described in 1952. Traditional lymphangiography was done through the feet. So these pictures show the injection of methylene blue between the web spaces of the feet, of the toes. And that methylene blue is picked up by lymphatic vessels on the dorsum of the feet, so it paints them. And then we do a cut down on those lymphatic vessels and cannulate them. And what you're seeing here is this tiny 30 gauge needle, tiny, catheterizing or cannulating this lymphatic vessel along the dorsum of the foot, and it's secured. And then this needle is connected to this plastic tubing through which we're going to inject the dye that we're going to use to paint or opacify the lymphatic system. This is a picture of how they did it back in 1952 when they reported it in the literature. And what you're going to hear me talk about as the dye that we use for lymphangiography is a dye called Lymphatic. That's the proprietary name. What it is iodized poppy seed oil. And the iodine concentration is very high. So you can see here, it's 480 milligrams of iodine per milliliter compared to the water-soluble dyes that we use to inject into the veins and the arteries. And this Lymphatic is very, very radiopaque because of its high concentration of iodine. These are spot radiographs of our needle into the dorsal pedal lymphatic vessel, injecting that Lymphatic dye into a lymphatic vessel. And we're watching the dye travel up the calf, up the thigh, all the way into inguinal lymph nodes and into pelvic lymph nodes. And we continue to watch it traveling up the lymphatic system in the retroperitoneum here, and eventually it's going to go up and hopefully make its way to this abdominal structure here, which looks like a lymphatic vessel because it's very small in this patient. It has different configurations, but this is the cisterna chyli. And if you dig deep into your medical student brain, you in your anatomy class, you may remember that the cisterna chyli is against the lower thoracic upper lumbar vertebra, and that it's the largest lymphatic structure in the abdomen. And sometimes that structure is what we target to get into the lymphatic system, because up to now I've only described opacifying, injecting dye into the lymphatic system. So compare that cisterna chyli to this cisterna chyli, which is much bigger and easier to access. And in this case, we've gotten into this cisterna chyli, we accessed it and injected more dye into it. And you can see that there is a leak or extravasation into the right hemithorax. This is a right chylothorax. So pedal lymphangiography is very time consuming because dye in the lymphatic system doesn't travel as quickly as dye in the veins or in the arteries, since lymphatic fluid travels really slowly in the lymphatic system. So although pedal lymphangiography was described in 1952 and was the modality or the way, the technique we used to inject dye into the lymphatic until recently, in 2011 and 2012, this new technique was described called intranodal lymphangiography that has facilitated the use of lymphangiography to perform lymphatic interventions. And what intranodal lymphangiography is the injection of dye. These are the two case reports describing intranodal lymphangiography in 2011 and 2012. What it is under ultrasound guidance, we access a lymph node in the groin and we inject Lipiodol into an inguinal lymph node. Here you can see that ultrasound image with the lymph node right here and a tiny needle in accessing the lymph node through which we're injecting the same dye, Lipiodol. Okay. We are opacifying those inguinal lymph nodes. You can see that needle here in this lymph node that we've accessed, and the Lipiodol is traveling upstream and opacifying the inguinal and the pelvic lymphatic system. And again, we watch it travel upstream all the way to the abdomen and pelvis. Since then, there have been some case reports describing other ways of getting into the lymphatic system. One of them is called transvenous retrograde lymphangiography. And through that technique, if you remember back to anatomy again, you also can remember that the thoracic duct, so this is a cisterna chyli, which I talked about, and then it is connected to the thoracic duct, and then the thoracic duct typically empties into the central venous system between the internal jugular vein and the left subclavian vein. Okay, so what we do with transvenous access is that we access a vein typically in the left upper extremity and advance a catheter into that outflow of the thoracic duct and catheterize the thoracic duct backwards. And that's what you're seeing here. We have accessed that left upper extremity vein. This is our sheath. This is our catheter. We're injecting water-soluble contrast into the central venous system, looking to see if we can find reflux into the outflow of the thoracic duct. And here is a catheter engaging the outflow of the thoracic duct. And here we're advancing a tiny catheter, a micro catheter, through that bigger catheter backwards to catheterize the thoracic duct. The problem, and here we've advanced the catheter all the way down to the cisterna chyli. The problem with this technique is that although it sounds that it's as if it were the most straightforward technique, it's really difficult to perform because there are a lot of valves, what we call terminal valves, in this portion of the thoracic duct. And it's very hard to advance the catheters backwards into the thoracic duct through those valves. But it can be done. Here's our catheter, and here's the cisterna chyli in that patient who had a leak over here. So another technique is direct percutaneous thoracic duct lymphangiography. And again, these are techniques just to inject dye, get into the lymphatic system, inject dye into the lymphatic system. This one can be performed using ultrasound or using fluoroscopic guidance. So using ultrasound, you try to find the thoracic duct, which is labeled here, under ultrasound, and then you access it using ultrasound, and again, catheterize the thoracic duct backwards. Here, we're doing it under fluoroscopic guidance instead. So to do it under fluoroscopic guidance, you have to do the lymphangiogram, either the pedal or direct intranodal lymphangiogram, in order to inject the dye and opacify the thoracic duct first, and then be able to target that cervical portion of the thoracic duct here and access the thoracic duct directly without going through the vein and bypassing those terminal valves. So you access it directly through the neck, and then you catheterize it backwards. And here is the microcatheter going backwards into the thoracic duct. So now what?
Time for the presentation is now expired.
Now I'm going to show 4 very quick cases of lymphatic interventions. Why do we opacify the thoracic system? Basically, in general, most of the time to treat leaks, although there are other causes or reasons to catheterize the thoracic duct. One is chylothorax, when patients have a lymphatic leakage in the chest. And this case is a patient who had mesothelioma, underwent surgery, pleurectomy and decortication by cardiothoracic surgery, and developed a lymphatic leak on the right side of the chest. We did the lymphangiogram, we identified the leak, and here we are accessing the cisterna chyli, and we're advancing wires and catheters up the cisterna chyli. Here you can see chyle in our microcatheter. And now we're going to block that leak using a variety of embolization agents. You're seeing coils here. Here is the leak. It's more evident because it's still below our coil pack, but we extended that coil pack across the leak, and then we glued. This is glue, not Lipiodol. This is glue, which is an embolic, basically sterile crazy glue. And we blocked that leak. Some patients have non-iatrogenic chylothoraces, so leaks in the chest that are not secondary to surgery or procedures. And that's the case for patients who have plastic bronchitis. And patients with plastic bronchitis, they have shortness of breath, and they cough up these white casts. And you can see in this case, they infused methylene blue into the lymphatic system, and you can see the methylene blue when the pulmonologist is doing the bronchoscope. This is how the casts look upon bronchoscopy, and this is how the lymphangiograms look on those patients. They have a lot of large and numerous lymphatic vessels where they shouldn't have them. So what we do is, again, we embolize or block the thoracic duct. This is the bronchoscope before treatment and a couple days after treatment. And eventually, sometimes, most of the times, this resolves and they stop producing those white casts. The traditional treatment for chylothorax is surgical. So the cardiothoracic surgeons open the chest and ligate the thoracic duct. That's what we are seeing here. These are the surgical clips after thoracic duct ligation, but we're doing the lymphangiogram because it failed. The patient still had a leak into the chest even after thoracic duct ligation. And the reason for that is that patients can have lymphatic vessels bypassing the thoracic duct, or can develop them after the surgery. And you can see the leak here, and you can see those extra lymphatic vessels bypassing the surgical clips. You can see them here. You can see that our wire cannot go through the clips because the thoracic duct is effectively clipped by the surgery that the surgeons did, but these vessels are still open. So we glued them with that sterile crazy glue, and the leak stopped. And lastly, another type of leak in the chest is one around the heart in the pleural cavity, in the pericardial cavity. And that's what we're seeing here. It's called chylopericardium. And in these lymphangiograms, what you're seeing is a patient who has a lymphatic malformation in the mediastinum around the heart. So they're accumulating lymphatic fluid around the heart. And despite surgery, a pericardial window to relieve that, the patient still produced lymphatic fluid. So what we did is we got into that abnormality. We treated it as we traditionally treat lymphatic malformations, which is by injecting a medication called a sclerosant, which basically ablates the inner lining of those abnormal lymphatic vessels. And then we embolize the thoracic duct, as we usually do, and the chylopericardium resolved. Thank you very much. If you have any questions, please feel free to email me. And this is my Twitter link. Thank you very much.